Thank you very much to ASI again for sponsoring and providing drinks and nice finger food. And thanks for everyone for coming. So I just want to say our speakers tonight, we are very lucky we have some very good endocrine academic surgical input. So first speaker is Dr. Anthony Glover, who is an endocrine surgeon at North Shore, VMO I think, aren't you? He has many strings to his bow. He is an academic researcher in thyroid cancer and other endocrine tumours, and that will become apparent in his talk. He has been an NHMRC fellow, and as of today, he's just been announced as New South Wales Cancer Institute fellow, and he has a widespread research interest at the Garvan. And in addition to that, we have a visiting endocrine surgeon from UCLA, Eric Kuo, who will be also presenting, who's literally only here for a few weeks but's been dumped on already. But without further ado, I'll get Anthony to kick off.
This is your one, isn't it, with the numbers?
Great. No, thanks, Di, for that, and thanks, Gay, for organising this great event. So, I think I'll put it on the slideshow. So just as the introduction tonight, I thought I would present an overview of genomics. Down there, yeah.
Sorry. I will... That's yours?
It's this one here, I think, yeah.
I'm getting rid of that. That work? There it is.
Oh, there it is. So we just put the slideshow. Okay, excellent. So I thought, as Di was saying, I'm actually still an NHMRC fellow at the Garvan, but in my part-time, I'm also an endocrine surgeon with the team at North Shore. And my fellowship is actually looking at studying how we can apply genomics and other omic technology into thyroid cancer and endocrine cancer research. So I don't have any commercial disclosures, but I've obviously got a bias to the question of whether genomics has a role in thyroid cancer, given I work at the Garvan and that's my fellowship. But I hope to provide a summary of where I think we are with genomics in thyroid cancer in Australia, and also some of my experiences during my fellowship in the US. So this is a tweet. If you're not on Twitter and you're interested in academic and thyroid cancer research, it's really useful. But this is a tweet from a thyroid cancer patient and a patient advocate from the UK, Kate Farnell. And I think this tweet kind of summarises well how we are with advanced thyroid cancer now. We have a lot of different treatments available with the new TKIs. We still have a role for surgery and radioactive iodine ablation. But our patients are living longer, and it's more like a chronic disease. And how do we decide how do we treat our patients? So I think understanding thyroid cancer biology, and especially the genomics, has a major role in advancing and improving the care for patients like Karen. So when you hear genomics, it's kind of a buzzword. It's often not really clear what people mean. The NIH defines genomics as study of a person's entire genome. Mainly in cancer research, we're not quite at that stage yet, and usually when we talk about genomics, we talk about panel testing, so testing multiple genes. But I think in the future, as whole genome sequencing becomes more available, and especially the analysis becomes more possible, we will move more into genomics, more into whole genome sequencing. But at the moment, it's generally looking at panel sequencing. So I'll present a quick case to how genomics has been used. So this is a patient that I saw in the clinic with Vanessa Zhang and Maddie Guild recently. He was a man in his 40s who presented to his local hospital last year. He had a sore throat and dysphagia. He was found to have a thyroid nodule, had a biopsy, which I think was atypical, and was taken to the operating theatre for a right hemithyroidectomy. At the time of surgery, his surgeon unexpectedly found that this was a cancer and it was invading his right recurrent laryngeal nerve, which had to be resected. He, after doing the right hemithyroidectomy, The surgeon finished the case and the pathology came back as a poorly differentiated or insular thyroid cancer. The patient had staging with a PET CT and an ultrasound, which showed he had extensive lymph node involvement on the right side and possible disease in his chest as well with a right paratracheal lymph node, which was avid on the PET. He was taken back to the operating theatre to clear his neck, so he had a completion thyroidectomy and a lateral neck dissection, and then had radioactive iodine ablation. Following that ablation, the disease in his chest was shown to be radioactive iodine avid, and he had external beam radiotherapy to the thyroid bed and had his cancer sent for oncopanel sequencing. So the team for this patient, they sent it for Foundation 1 testing, which is one of the commercial tests available from the United States. In Australia, this test costs about $5,000. Not sure what the situation was with this patient, but this was the snapshot of the summary. So what it showed was that he had an interesting driver mutation, which was a RET fusion, which I'll talk about a bit more in a minute. And he also had what we usually see with advanced thyroid cancer, had a TERT promoter mutation. And interestingly, he also had a VHL mutation as well. So at the time, he had possible low volume chest disease, but no other disease. So that was the results there. And then he was followed up, and in August of this year, he had another PET, FDG PET, and it showed that the disease in his chest was no longer avid, but he had a new nodule in the left side of the neck, so the opposite side from his original presentation. So he was referred to Vanessa and Maddie at North Shore to consider what his further treatment should be. Should this patient, given he has a RET fusion, go onto the trial of LOXO 292, which is a selective RET inhibitor, or should he have any other management? So I saw him with Maddie and he was well, he was asymptomatic. He has a known right vocal cord palsy, and on the left he has this small nodule here. So it's about 1 centimetre. He had his left vocal cords was working. So after this staging CT, he had no other disease anywhere else. We spoke to his original surgeon and recommended that he has that resected. We didn't feel that there was a role at the moment for targeted therapy. And I'm pleased to say he had his surgery. This was removed. There was no involvement of the nerve. And he went home the next day and played in a golf tournament and won his tournament. So it's a victory for everyone. So I think this case, even though genomics was used, it probably hasn't made any difference to his outcome. Was it worthwhile? I suppose time will tell. Like we know with him in the future, he's going to have a high risk of developing systemic disease, and we'll have that information ready for him to be treated with targeted therapy in the future. But I think with patients with poorly differentiated thyroid cancer, there's always a role to consider if they do have radioactive iodine avid disease. Like I presume his disease in his chest is more differentiated, and that has been treated by that. Whereas the disease that was in his neck was more differentiated. So this is kind of the roles I see how genomics can affect thyroid cancer care. So with diagnosis, many of you probably have heard of the different tests that are used in the United States. They are available in Australia, but the cost is around $3,000 to $4,000. So it's very rare that patients are willing to pay for that, and it's not obviously covered by any of the health funds. But they do have a role in defining which atypical nodules are likely to be cancer or not. But I think the way that we can use genomics in Australia is especially with genotyping and genotype-driven trials, understanding the significance of different driver mutations, and then hopefully in the future using that knowledge to develop new tools to risk stratify our patients. I think another major part of genomics, which I won't talk about tonight, but which we are very interested in at the Garvan, is understanding the genetic basis for the risk of cancer. So at the Garvan, one of the major cancer genomic programs is the RISK study, which is performing whole genome sequencing on young patients, so anyone with a cancer under 40 or 2 cancers diagnosed under the age of 50, to try and get a better understanding of different mutations and their risks of different cancers. And finally, I think there's a major role using genomics to discover new biology. So I just start off talking about how I can see genotype working. So those of you who aren't familiar with the molecular biology of thyroid cancer, basically there's three main pathways, so driver mutations for papillary, poorly differentiated anaplastic thyroid cancer. And they all lead to the same thing. So they all activate what's called the MAP kinase pathway, which drives cellular growth and cellular division and cancer growth. The interesting thing is each particular pathway, so with BRAF, you get a much greater activation of this pathway. So you see a much wider range of difference in the differentiation. So some patients with a BRAF-driven cancer may have a lot of differentiation, others would have not as much, whereas RAS-driven tumours are generally more differentiated. And what happens when we get more advanced cancers is they get modifying mutations, so especially of TP53 and TERT mutations. And the other part of the driver mutations we're starting to understand more, and especially with targeted therapies, so like the patient I presented, are the role of fusions, so especially RET, NTRK, and ALK fusions, which are quite rare drivers, but there are effective targeted therapies. And there's also a number of other pathways that are important, which we're starting to understand now, so especially with the SWI/SNF pathway with epigenetic changes and the mismatch repair pathways. So I think where we are currently in Australia, this is kind of my overview. So I think we know lenvatinib works really well for patients that have radioactive iodine-resistant papillary thyroid cancer or poorly differentiated thyroid cancer. And the trials obviously were done without knowing the genotypes. So I think as the first-line treatment, it's an effective choice. But I think for some of the fusions, there's different trials, and with the LOXO 292 trial running at the moment at North Shore, and the other agents have been trialled in different basket oncology trials, and which include thyroid cancer patients and had good outcomes. I think one area where genotype-driven treatment is really important now is anaplastic thyroid cancer, so especially with BRAF-driven cancers, which have a better response to BRAF and MEK inhibition. And some of you might have seen this patient before. I think it's probably been presented at this meeting, but this is an anaplastic thyroid cancer patient of Mark and Bruce's, who presented with a very fixed mass in the neck, obviously inoperable cancer, had lenvatinib and external beam radiotherapy with a remarkable response, ended up having a total thyroidectomy and had good local control. And when you look at his initial pathology, we can kind of predict what we know now about the biology. So this is a BRAF negative anaplastic thyroid cancer. Also didn't have any ALK expression on immunohistochemistry. So most likely this is a RAS-driven cancer. And it fits with what we know from molecular biology and also different mouse models of thyroid cancer. So the question is, how should we test for these patients? So I think the key to the testing is to involve an experienced pathologist. So we're very lucky at North Shore with Anthony Gill and his team. Many of these cancers, they're able to do different screening with different IHC stains to try and predict which patients should have further testing. We have some onco panels available. So St Vincent's Melbourne have a small panel. Hopefully at North Shore in the very near future with Rory and Bruce, we may have a panel as well. And there's also some oncology trials, which is running at the Garvan, which I'll briefly talk about. And the other thing is the commercial tests. But the question is it worth the money? So this is actually a real note, the $5,000 note in the US, which is made in the late 19th century for trade between banks. But for most of these tests, that's what's going to cost for us to get them done. So is that worthwhile for patients to pay for? It's hard to know. So I think when we have trials available, especially the Australian government is very supportive of this kind of technology, it's useful to make use of them. So one of the big trials available at the moment in Sydney is the MOST trial. So this is running from the Garvan. It's for patients with all types of cancer. Basically, the inclusion criteria is that they have to be fit and independent, and that they have to either exhausted or expected to exhaust or known conventional treatment. It's funded by the Medical Research Future Fund. So with a plan to sequence 5,000 patients, so far they've recruited almost 2,000 patients and reported genomic sequencing for about 1,800 patients. So they use a variety of panels, including Foundation Medicine, and most currently a panel with 500 genes. Just an example of the activity of the most, so I'm part of the molecular tumour board at the Garvan. So in the last 4 weeks, they discussed 93 patients and 2 with thyroid cancer. One, which similar to the patient I presented, had a RET fusion, and another ATC with no actionable mutations, but some interesting mutational profile. So I think this is available, and it's funded, so it doesn't have to pay for the patient. So it is one option while depending for patients that we don't find mutations through our other pathways, and hopefully soon we'll have a similar kind of panel available at North Shore. So the other major role, I think, with genomics at the moment is to, the red's supposed to be underneath discovery of new biology, and I think in the future, hopefully we can use our understanding of new biology to improve our risk stratification, which I think is the big kind of thing that we can achieve with genomics and thyroid cancer. So for the last 2 years, as part of my NHMRC fellowship, I was lucky enough to spend time in Jim Fagan's lab. So many of you may know him. He's an endocrinologist and the past president of the ATA, and he runs a big lab at Memorial, which focuses on using mouse models to understand what role different mutations take in thyroid cancer. And I was able to start a project with him there that's been continued by Brian Unch, who's an endocrine surgeon, and Chris Murphy, who's a very talented postdoc in the 6th year of his postdoc with Jim, but looking at how different mutations identified by genomic sequencing can can affect thyroid cancer biology. So at Memorial, they use a panel for all their patients. So it's called MSK Impact. It's got 470 genes on it. And every patient with advanced cancer that goes to Memorial, they offer this panel, and it tests both the tumour and germline. There's almost 40,000 patients now that have been sequenced, and all the data is placed on an online repository, so any researcher at MSK can use that data. And there's more than 500 thyroid cancers have been sequenced. At Memorial, they don't offer this service unless you're a patient, so you can't send your DNA there and get it done. You have to actually be a patient of Memorial to get it done. And they charge the health funds about $4,000 to do. So at Memorial, after they had done their first few years of sequencing, Jim found that this particular gene called RBM10, which had never been described before in thyroid cancer, was the 4th most common mutation in their papillary cancers. So you can see these patients, as you expect from advanced disease, most of them have metastatic disease or locally advanced disease. And my project was basically looking at what function this gene could have. Looking at the other genes that were mutated, it kind of fits the classical patterns we know of advanced disease with drivers either in BRAF or RAS and TERT mutations. So what we did is we used the mouse models, so knocking out this particular gene, RBM10, in a thyroid-specific way and crossing it with a mutant HRAS to see if these mice what would happen. And basically, with these mice, this is some recent results from Brian, after about 18 months, they start to develop lung metastasis. So if you have a mouse, similar to a human, if they just have a RAS mutation in their thyroid, they get hyperplasia or nodules, but they don't get cancers. So when you add this mutation, they get metastatic cancers, which look like poorly differentiated thyroid cancer. So once again, Memorial, they use a very genomic focus to their research. So they have all their cell lines have been sequenced in a similar way. So we picked some cell lines to try and represent what we see in patients. So with both BRAF and RAS-driven tumours, and we had a couple of cell lines that actually had RBM10 mutations. So this particular gene controls alternative splicing. So this is just some of the functional work showing how this loss of this gene could lead to thyroid cancer. So this is a particular target of this gene's protein, RBM10. So when it's this is tenacin C, which is a protein involved in the extracellular matrix and breast cancer. So when RBM10 isn't present, there's splicing occurs, and this particular gene is translated into a protein. But when RBM10 is present, which it is in most people, then this particular protein this particular gene isn't translated into a protein. And Jana has recently just shown how those different isoforms of the protein will change when RBM10 is present or not, and also the half-life of the tenascin C messenger RNA is increased when RBM10 is lost. And this is just showing some fluorescence against that particular protein. So in the mouse, so the green is the protein. The one on the other side is the blue is a different mouse model, which has RBM10 there. So you can see when RBM10 is present, there's not much of this protein around. And this is one of the human cell lines just showing when you introduce RBM10, the protein becomes more cytoplasmic. So I think this is just a quick example of how we can use genomics, a discovery from sequencing patients to understand biology. And then hopefully the next step would be to try and translate that to our patients. So if we can introduce genomic testing as part of FNAs and prospectively follow these patients, hopefully we may be able to understand the risk of which patients will develop more extensive disease and have a better stratification so we can choose which patients should be offered a hemithyroidectomy versus a total thyroidectomy. So this is what I'm working on at the moment at Garvan, and I'm hoping the Medical Research Future Fund will fund me one day with $50 million. But basically it's doing a similar kind of thing, but trying to genotype patients and then using those samples for discovery projects. And also having the capacity and using the resources we have available to offer treatment for advanced patients as well. So I think, hope I've convinced you that genomics does have a role in thyroid cancer. I think right now, for any patients with advanced disease that we're considering for clinical trials, we should always think, have we excluded fusions? Anthony Gill is always very happy to help if you need it. There's a great opportunity to reduce variation in clinical practice. I know we've been involved with the most. I've been able to get a few patients referred, I think, to North Shore that would have been treated differently if they weren't. But I think its best potential is to make new discoveries and hopefully translate them to clinical medicine. So these are my contact details. If anyone wants to know about any of those trials or has any patients, I'll be very happy to help you recruit them, and I'll be happy to take any questions. Thank you.
Thank you. That's great. So anyone have a question? Yes, Rory.
Actually,
RBM10 is X-linked, so was there any difference in gender with RBM10?
Yeah, not in the patients. So so there's similar distribution in the patients. So in the impact series, it's around 55% of patients are female, and it's similar with RBM10 as well. So yeah.
So you're proposing that it's a tumour suppressor?
Yes, that's right. Yeah.
Mm. Difficult to reconcile if there's no gender bias.
The other in women, the other allele will be inactivated. So, and the somatic frequency in women is around 50%. So.
So can I just ask
Yeah.
you, this is obviously endocrinology moving into the genomics era, like oncology's been trying to do for a while. We're limited in Australia by A, the cost and the availability of the testing, and B, the access to the drug, be that on a clinical trial or provided, privately or TGA approved. So where do you see Australia in relation to this? How long is it going to be before we can tailor our treatment to our patient's mutation?
Yeah, well, I think Australia can really lead this. Like I know a lot of Memorial, their patients are highly selected. So there'll be some patients that have come for third or fourth opinions. So we're seeing patients that are much more representative, I think, of the general community. I think that's right with the some of the drugs are available, but with compassionate access. We know obviously lenvatinib is available through the PBS, but I think it's an area we need to get better data to be able to convince the government to list these drugs and show it does make a difference. Yeah.
And the other issue is that theoretically, if you find a very specific drug to target a mutation and you get a great response, like in your patient with anaplastic who had the huge mass, what's the concern about perhaps killing that particular clone of cells and allowing another clone of cells to take over and patient getting resistance or rapid recurrence? Is that an issue, do you think, in real life?
Yeah, I think, definitely. But as we know, like with the lenvatinib patients, many of them have stable disease for extended periods of time. But I think it's still something that we're beginning to understand and working out when we can stop treatment, and deciding a response. So yeah.
And maybe lenvatinib's good because, I'm not deliberately putting in a plug for lenvatinib, but it's good because it's a multi-kinase inhibitor. So we're not actually targeting a specific, it's not such a specific targeted therapy, and therefore it seems to have prolonged remissions in quite a few patients, anecdotally anyway.
Yeah.
Okay, any other questions? Yeah, Steve.
Thank you, Anthony, for a wonderful overview.
Yeah.
I'll repeat that. Thank you, Anthony, for a wonderful overview. I'm just wondering whether you had any experience with circulating microRNAs. People have done some work in the thyroid space, and there's certainly a big space in other types of cancers, and it may be very feasible and ideal for thyroid cancer because we remove the affected organ and then we can hopefully detect recurrence that way. Have you?
Before I went to the Garvan, I used to be part of Rory and Stan's lab, and Stan Sidhu especially has had a long interest in circulating microRNAs. So I think those kind of biomarkers have a great role, but it's just understanding how to use them best. I think that obviously circulating tumour DNA, methylation profiles, all these kind of tests, they all have great potential, but it's just deciding how we're going to use them. So
Maybe just give Gay some exercise.
I do need it.
What are we doing at the funding level for? I mean, it's to follow on Diane's question in terms of advocating for access or better access for these types of technologies. I mean, I know the government had a big genomics announcement of about, I think, what was it, 500 million?
Yeah, that's right.
Reprocessing funds, they're good at that. But,
So all the Garvan's cancer genomic programs, which is mainly MOST and also the risk study, so that received $50 million last year from that initiative. And I think, the funding bodies are quite interested. I think, as I was saying, in Australia, we've got an advantage. We have access to tissue. We don't have so many ethical issues as they do, especially in the United States with using patient samples. And we have established tumour banks. So at North Shore, we've had our tumour bank since the 1990s. So we have the resources there to do it. And I think, we're relatively lucky compared to other places internationally. I guess we don't have as much industry involvement, and that's something we can work on more. But I think this is one area that the federal government especially have made it as an area of focus, and especially using the funds which are more targeted through the Medical Research Future Fund compared to the NHMRC. They've made it clear that they want these kind of research to be done in Australia and to be led by Australia.
So there's just one other aspect of the MOST trial which concerns me, and that's the deficit in the germline assessment. So you mentioned that there's no germline assessment, so that's not going to be too much of a problem with thyroid cancer, for which germline variants are uncommon other than RET. It's a big problem for ovarian cancer. How are you protecting yourself against the incidental discovery of a germline BRCA mutation?
There is some genetic counsellors involved with the molecular tumour board, so they have patients, they think the mutational profile looks suspicious for a germline mutation, they'll report that back to the clinicians, but they're not testing specifically for germline mutations. But there is some of the patients that are on the most trials, so probably maybe 20 to 25% are also part of the risk study as well. So they're having whole genome sequencing
so the patient
on germline.
The patient you presented with the VHL mutation, did you follow that up for germline?
Yeah, I think they were recommended for it. Yeah, for that patient. Yeah. But I think it is a consulting program, so they're not actually taking. It's not a trial where the patients are referred. It's a consulting service that provides a molecular tumor board report, and then if there is a sub-study available, they recommend that sub-study is available. But if not, it's up to the patient stay with the referring clinician, so the oncologist usually.
Great. Okay. So tonight, thank you.
Yeah, thank you,
I'd like
Di.
you to sit down and have a drink. So we're not going to stick to a definite timeline tonight because there are two members of the audience who've got children that finished the HSC today but have still come along when they should be at home celebrating with their children. So we're going to try and finish early. So my next speaker is Dr. Eric Kuo, who's literally only just, I was going to say got off the boat, but got off the plane from UCLA, and he's yes, and he's a senior surgical fellow from UCLA, and he's stepped in to give a case presentation for us. Thanks, Eric.
Yeah, nice to meet you all. My name's Eric. I'm one of the surgical residents at UCLA, so I'm still a trainee in my second to last year, and I've been Dr. Saiwak and Dr. Sidhu and Dr. Glover have been gracious enough to have me for the month to visit. Thank you. So I'll be presenting a case today that was seen at the North Shore Public Hospital. This is a patient with locally recurrent papillary thyroid cancer who's seeking pregnancy. She's a 35-year-old Brazilian woman with locally recurrent papillary thyroid cancer. She had underwent a total thyroidectomy with a central neck dissection in November of 2017 for a 3.5 centimeter papillary thyroid cancer. 9 of 12 nodes at the time were positive, and it was found to be BRAF positive as well. She underwent radioactive iodine ablation, unable to tell from the notes kind of how much she received at that time. This was in January of 2008. A year later, or nearly a year after her surgery, she had a CT of the chest and ultrasound of the neck and surveillance, which showed evidence of a 1 centimeter structural recurrence in the left thyroid bed. In October of 2018, she had FNA of 2 suspicious lymph nodes, one of which the TG aspirate was greater than 25,000. And so she sought consultation with a Brazilian surgeon in her home country and underwent an attempted redo central neck dissection at that time. However, they were not able to find any abnormal tissue and did not end up removing anything. So post-operatively, about 1 month later, she had a PET scan which showed uptake in the neck in the exact same location where this nodule was seen on CT and ultrasound at the time. And at this time as well, her thyroglobulin had started to increase from 2 immediately post-operatively to now in the teens. She had a whole body scan which didn't show any evidence of abnormal uptake in the neck. However, an ultrasound was repeated which did show that this nodule had increased in size. This is when we met her at the public hospital. She had and after evaluating her, several additional imaging studies were ordered. She had a CT of the neck and chest, which showed a 7 millimeter nodule in the left bed of the thyroid, and again confirmed with ultrasound that it measured in its largest dimension, about 1.4 centimeters. This nodule was rebiopsied and was consistent with recurrent papillary thyroid cancer. So she underwent a redo central neck dissection in August of 2019. A total of 2 of 8 lymph nodes were positive, the largest being the index lesion, which was 10 millimeters in size, and did show evidence of 2 millimeters of extracapsular extension. And she also had a 2 millimeter focus of papillary thyroid cancer in a separate lymph node as well, and the remaining 6 lymph nodes were negative. And so I guess the question that we were bringing up for discussion here in this forum is, in this setting of a 35-year-old woman who is very, very interested in pursuing pregnancy, and a setting of recurrent disease with extranodal extension, are you going to give radioactive iodine? What is the timing of that? How do you counsel the patient about delaying this potentially for childbirth, and how do you prioritize that with her goals in life? So just kind of some quick review. Thyroid the development of the thyroid begins at the 24th day of gestation, and radioactive iodine administration, during this time can lead to hypothyroidism and cretinism. Obviously with my American bias, the American Thyroid Association guidelines from 2011 recommend delaying radioactive iodine approximately 6 months prior to pregnancy, and actually because breast milk also concentrates iodine, the recommendation is also to delay breastfeeding, so 6 weeks prior, or delay radioactive iodine 6 weeks prior to breastfeeding, and also for 3 months after as well. This was a meta-analysis whose purpose was to determine the effect of RAI on ovarian function and future pregnancy in patients with differentiated thyroid cancer. And overall, there was a meta-analysis of 16 studies looking at 3,000 patients, and the rate of absence of menstrual periods within 1 year of RAI was about 8 to 27%. This was pretty much always transit, and they regained menstrual function afterwards. They didn't see any significant increase in the rates of miscarriage, infertility, stillbirth, or neonatal mortality. Really the only sequela of RAI in this scenario they saw was an earlier onset of menopause in the late 40s rather than the 50s. So just the overall message of this is that RAI, when it's given well in advance of anticipated pregnancies, is quite safe. However, just to give a plug to kind of our own group here at UCLA, work with Dr. Liang, who sounds like many of you know in the endocrinology world, as well as Dr. Michael Ye. We looked at the effect of radioactive iodine on birth rates in women in California. We were able to do this using a registry, the California Cancer Registry, which is a population-level database of all patients with cancer in California, and we're able to link that with a database called OSHPUT, which is an administrative database that keeps records of of procedure codes and things like this. And so we're able to link patients with differentiated thyroid cancer with patients who have been coded to have spontaneous vaginal deliveries versus cesarean sections. And we were able to show that in about 1,700 patients, 8,000 of which did not have radioactive iodine, and 9,000 of which did have radioactive iodine. These are all patients who had differentiated thyroid cancer. There was a decreased birth rate that we saw in patients who received, in middle-aged women who did receive radioactive iodine, 11.5 versus 16.3 births for 1,000 women. And we also did observe as well that there was an increased delay until the time of the first birth. So although it appears that biologically perhaps that there is, appears to be safe for these women to have children, and there isn't any sequela as far as miscarriage, it does look like practically that these, this is a significant life event that is delaying pregnancy. Okay, that's all I have, and happy to open it up for discussion.
A topic of great fascination because we deal, as endocrinologists, we deal very commonly with females in their reproductive years, don't we, Anna? We have these lengthy discussions in our room. So do you think the decreased birth rate is because the women have a fear of cancer recurrence, or do you think it's a genuine fertility issue?
I don't think it's a fertility issue, just because of all of the data. It shows that radioactive iodine is safe. And so I think it is, this data is consistent with other data in patients who have chronic diseases who have delays in childbirth. And so I imagine it's more due to life circumstances of, frequently having to visit physicians and not being able to, set that up as a priority in their life at that time.
Okay, and similarly, that would be the reason for the delay until the first
Yeah,
birth. Yeah. Okay.
It's hard to postulate, yeah.
So, can people at the audience feedback as to what they think should be done with this case now? So, surgical management predominantly, would that be?
What's the post-operative thyroid globulin? That's the obvious.
Yeah, so looking through her records, I don't think she has had that. We don't have those records at this time.
We're still waiting on that. This is a patient of Bronwyn Corpus, originally from Concord, and we're just waiting on the first post-op TG.
Were all the thyroglobulins measured on thyroxine?
Yes, so she was on suppressive doses of thyroxine with undetectable TSH nearly.
So what do you think about the volume of her disease in relation to her thyroglobulin level?
I think it is consistent. You know, it seems like she has small volume structural disease, and her thyroglobulin is also appropriately low as well.
So her on-thyroxine thyroglobulin is 18. I mean, that's a generous thyroglobulin level. We'd normally expect to see that on structural imaging. Are you surprised that her disease was sub-centimetre?
I don't, at least from what I've seen, it wasn't a huge shock for me to see that, but I guess I've also limited experience in this as well. I did not see any records of a stimulated TG in our system, no.
So this is, I think, where, Anthony's talked about genomics for high-risk thyroid cancer, but in my practice, I would love to see genomics for intermediate-risk thyroid cancer, so that this kind of patient, you could actually predict what's going to happen to them based on the behaviour you might expect the behaviour of the tumour. Because we know that theoretically she's a young female and will do very well and will be cured, but along the way she's going to have, she already has declared herself as having bulky nodal disease that recurs, and it causes a huge amount of anxiety, particularly when you're trying to plan your family, etc. And there's this constant need for follow-up and need for discussion of what the latest thyroglobulin is. We call it TAS, thyroglobulin anxiety syndrome, and how to plan your life around that. And I have actually had a patient who had very low risk cured thyroid cancer, but she had a false positive post-ablation iodine scan with a focus in bone that turned out to be nothing. It was false positive, nothing seen on MRI, but who was so scared about thyroid cancer recurrence that she decided to not have any further children. Her thyroid cancer had been diagnosed in her first pregnancy.
I was thinking about that in reference to this patient. Are you confident that the disease represented recurrence, not persistent disease? Because if that's the case, it recurred pretty quickly. It recurred within 12 months. And that would sort of indicate somebody you perhaps might worry about allowing a pregnancy and then perhaps breastfeeding.
Yeah.
So that would be the only thing that I'd be worried about with this girl. Because she said, does she have children yet?
I don't believe she's had children yet.
Yeah.
I don't recall.
All these questions for a patient you've never met when you've just stepped off the plane, but yes.
Eric, you did a fantastic job because you're still jet lagged and we're very impressed. But I agree with you, Anne. I think it was persisting disease because I think if you look through the TGs, she never had an undetectable TG. And the question I had for the audience was, has anybody ever seen runaway thyroid cancer that starts with relatively low volume disease or low levels of thyroglobulin, where you might have allowed them to fall pregnant and then regretted it? Like, does it actually happen that we lose complete control of well-differentiated thyroid cancer through a pregnancy?
I think we had... It was David Cooper that commented on that, wasn't it, at that meeting at the Gold Coast? And he basically sort of said if they don't have structural disease going into a pregnancy and they've only got thyroglobulins, and he had some patients with relatively high thyroglobulins, and he let them go into a pregnancy because his belief was that he'd never seen disease get worse if they didn't have structural disease prior. So they could have evidence of disease, but as long as they couldn't see it radiologically. And Rory has taught me years ago that if they start off bad, so they're pretty good at the start.
That's great. Thank you.
Right, thank you.
I'm just going to...
Escape.
Yeah.
That one's yours. Well, you gotta go to it's a bit sensitive. Yeah.
Okay, I'm just going to... These are slides from your presentation that I'm going to skip down. So. Okay, so does anyone want to pause and have a snack before I start? Or feel free to go and grab some food. Is it coming to each table? Coming to each table, okay. So as I keep saying at these meetings, I won't be offended if you eat while I'm talking. Happens to me all the time at home. Okay, so I think we are going to finish quite early tonight, you'll be relieved. So I'm just going to talk about follow-up, because this is, I guess, from an endocrinologist's perspective, it is one of those things that's become very complicated. So we used to have a one-size-fits-all approach to treatment back when I was a registrar, and a one-size-fits-all approach to follow-up, and now we have tailored approaches to both. So this is a review that you probably will have seen that appeared in Nature Reviews Endocrinology at the end of last year by the Europeans, including, well, Schlumberger was the senior author. And it's actually a really good, it really encapsulates all the issues quite well. It's got a very clunky title, Follow-up of Differentiated Thyroid Cancer, What Should and What Should Not Be Done. That's the actual title of the paper. So the issues that I really grapple with are when to discharge the patient from care if they're low risk, excellent response, and we've now had some helpful I think clarification of that with officially written down guidelines, so that if we do discharge from care, don't worry, you can sit there, Veronica, because I'll sit here. So that if we do discharge from care and something bad happens, hopefully if we end up in court, we won't get into too much strife. This is a big issue. How often do we do neck ultrasound if we're low risk and if the TG is negative? I think the last issue is not really a big issue because it's fairly obvious that patients with high risk of recurrence who do not respond excellently to treatment need close follow-up, and this article says they should be followed every 6 to 12 months with serum TSH, thyroglobulin and thyroglobulin antibodies. Now, so in this review, and please don't read this because you won't be able to, it's a very busy slide. I just want to point out what they address. So they address how we estimate original risk. It addresses how we choose treatment, which now is really complicated, particularly for low and intermediate, and how we assess response. And dynamic risk reassessment based on response is now obviously the buzz phrase. And now, what should we do with follow-up? So please don't read this, but I kind of feel like I sort of know what to do from common sense, but if you need help, you can get it from this. And again, don't read this. This is how we assess risk according to ATA, which I think is way more helpful than TNM. As you know, TNM assessment in thyroid cancer is really designed for mortality, and it's not really suitable to our tumour type in differentiated thyroid cancer. Just to remind you that low risk is fairly obvious, and follicular thyroid cancer rates a separate mention in this. So low risk follicular thyroid cancer means less than 4 foci of vascular invasion, and if you have more than that, you actually upscale to high risk disease. So follicular thyroid cancer with extensive vascular invasion, obviously high risk, and these are the risks of recurrence. So intermediate risk actually does mention BRAF. So genomics or genetics will come into play more and more with each subsequent upgrading and iteration and updating of the guidelines, I think. And who knows, we'll possibly have a panel as part of our risk assessment in routine care. Now, so again, don't read the fine print, but this is what's now new. So we now, instead of having one column of guidelines as to what to do, we now have 3. So we have response based on the criteria I've already mentioned: excellent, biochemical incomplete, indeterminate, and structural incomplete. And we have what defines that category. And now we have to have 2 new columns, because we have proposed definition for patients treated with total thyroidectomy without radioactive iodine, and patients treated with thyroid lobectomy. So we're all seeing lots of these in our rooms now and trying to decide how best to follow them up. They've gone out on a limb and they've actually given you thresholds for thyroglobulin in these definitions, but they have actually said at the bottom these thresholds still need wider validation for clinical practice. And I'll just draw your attention to this. They're not really suggesting that we need to do stimulated thyroglobulins on patients anymore, and I had certainly stopped doing that pretty much in most of my patients for follow-up, even though we do it at baseline when we're having initial treatment. So if you have a sensitive thyroglobulin assay, well, we are not sure we've got the Roche assay, which is sensitive down to 0.2, then follow-up using that assay probably doesn't require stimulated TG values. So they've defined how to follow up patients who've had hemithyroidectomy and still have a thyroid lobe. And they've suggested that, yes, measuring thyroglobulin is useful. Others have suggested it's not useful. And they've suggested that you can have a basal thyroglobulin of less than 30 and then use that as your baseline or to follow up what might happen afterwards. But to me, I think thyroglobulin in someone who's had only hemithyroidectomy is a very clunky and not very useful way of following them up. It's going to have to be neck ultrasound. So just to let you know that it's becoming very complicated. So I have a couple of cases on how to follow on patients who I grapple with that are sort of low to intermediate risk. But just to summarise, we had the 2 big studies called Estimable and High-Low, which were published in the New England Journal some years back, that defined how to treat low to intermediate risk patients at baseline, i.e. what dose of radioactive iodine should they have, whether it's safe to have it with or without thyrogen, should it be with thyrogen or should it be with TSH withdrawal? And we've all moved on from that now. We know that it's safe to give low doses and it's safe to use thyrogen stimulation. You don't have to withdraw from thyroxine, so that's well established. So these studies were then pursued to the 5-year follow-up, and now they've both been published in Lancet Diabetes and Endocrinology, Estimable 1 and the follow-up study for High-Low as well, and they both had 5 to 6-year follow-up. So they've clarified now that the initial stimulated thyroglobulin at 1 year, at the first radioactive iodine is prognostic for 5-year outcome, and Mark has sort of published that as well from our data. If you have a low risk excellent response, you do not need to suppress TSH, and I generally try to suppress TSH until I really know what's going on. So I do a bit of TSH suppression in the first 6 months. But yes, we can relax TSH suppression certainly at 6 to 12 months in low-risk patients who look like they've had an excellent response. So then what do we do? So let's say they're cured at 1 year. What do we do with them? And what they've said is that there's an 8 to 67%, based on different studies, false positive neck ultrasound rate, so that if you keep doing annual ultrasounds on these people, you're going to create a lot of expense and probably a lot of morbidity from false positives. So they are suggesting that you cease doing a neck ultrasound at 5 to 10 years, and if they're going to recur, 80% of recurrences will have occurred within that first 5 years. So I think there's now, some of this stuff's now written down, and I feel a bit safer about recommending that to patients. If you have biochemical incomplete response, and we all have lots of those patients, where the TG is still positive, it's only low, it might be about 2, the neck ultrasound doesn't help, and you're not quite sure what's going to happen. So we watch the trajectory. I think we're already doing that because it seems logical. We still don't have to suppress TSH very much in those patients, so they're allowing a TSH between 0.1 and 0.5 in those, so very specific TSH guidelines for these people. Many of these will spontaneously improve, so I think that in the paper it's something like 60 or 70% of them will actually get better. And obviously beware of thyroglobulin antibody positive patients, and especially if the titer is rising. So they do allow you to use that as a surrogate marker of persistent disease. And this is where we need biomarkers. So to come back to Steve's point, circulating microRNAs might be something that's going to be really useful for patients who are thyroglobulin antibody positive. And I've got plenty of those. So just a couple of cases. Follicular variant PTC in a youngish female, age 38, and operated on elsewhere. So we see a lot of these. She had a total thyroidectomy and a central and lateral node clearance at Tamworth in 2014. It was actually a very small cancer, 8 millimetres, no extrathyroidal extension, but she had bulky nodal disease. I can't actually give you the exact details of her histopathology, nor can I tell you what happened, but she was sent to Westmead, where she had her first radioactive iodine dose. I don't know what dose they gave her. And then she ended up seeing me in 2015, and her thyroglobulin was 39, and I gave her a second dose, and I did that for a few reasons. A, because I thought she needed it. B, because we use the stimulated PET scan sometimes for good information when they have their when they come into hospital and have their dose, and obviously the post-ablation RAI scan, and that was actually negative. So I had useful information that she's no longer iodine avid, and probably that's not a very good treatment anymore. I had some useful stimulated PET information that maybe there was a lymph node on the right side, although it wasn't clear. And then she had neck ultrasound from then on as a way of looking at things, and thyroglobulin. Long story short, she actually had a few false positive neck ultrasounds requiring biopsies. She had a lymph node on the neck, on the left, which was stable, got better, and then it got worse again. So most recently, it's gone from 9 millimetres up to 14 millimetres, and her fine needle biopsy is again clear. And the reason that we pursued this was because her serum thyroglobulin unstimulated is between 2 and 5. And so presumably a stimulated thyroglobulin will be somewhat larger than that. So I've put her as biochemical incomplete response, but in actual fact she's what we would call indeterminate response, so between 2 and 5 with sort of negative imaging. And the question is what to do with her, when to scan her, and when to use PET scanning. And I'll just show her, this is the most recent neck ultrasound that resulted in a biopsy. This lymph node here, it's lost its central hilum. It was biopsied and it was normal lymph tissue, so it was a false positive on ultrasound. So yeah, illustrating the point that false positive neck ultrasounds are common, and patients commonly have low-level persistent TG positivity. However, her trajectory has been stable rather than rising. So who in the room would do a PET scan on her? She had a PET scan in 4 years ago. Who would do another PET scan on her, or who would wait till her TG gets a bit higher? Anna.
Before we answer that, can we ask what the lymph node actually showed on biopsy? Was it reactive, or did you do a TG assay on the assay?
Yeah, so interestingly, I wasn't actually going to bother biopsying it, but she went back to Tamworth with her ultrasound, and her GP organised a biopsy of it without actually discussing it with me, and they didn't do TG washings. And I think that's a really good point, because if I'd organised it in Sydney, I would have done that. However, I'm not sure that would have changed my management. So let's say her serum TG remains 2.5 or 3, and her washings come back 25,000, similar to the previous case, and all you can see is one lymph node. What are we going to do about that? How's it going to change management? we're going to watch that node, aren't we? Are we going to submit her to an operation for one node? No.
Well, that's the only node we can see.
But do we need to operate on it now?
Well, if it was positive on TG sampling, I would operate on her.
Okay, so you'd operate on someone whose serum TG is 2.5 and not rising on the basis of one lymph node. Lee, would you do that?
I think you've got documented nodal persistence. Why leave it there? If you can ablate it with ethanol and get rid of it, that's fine.
She's already had 2 neck operations.
Ablate it with ethanol, which
Yeah.
would get rid of it, and I think that'd be the perfect answer for her.
Okay, so ethanol ablation. Any other strong feelings in the room? Yep.
No, saying depends on where it is.
Yeah, okay.
If it is in an area that's easily accessible, you will go for surgery, but if it's difficult, maybe like a Prof said, some kind of an ablation, you will do something about the node. It's a close to 1.5 centimeter lymph node.
Rory.
So like you, we've got loads of these patients,
Yep.
and they just don't do much over years or decades, and just keep watching them. But the only thing that bothers me is that she had N1B disease from a sub-centimetre primary.
Yeah.
And I just want your opinion. My anecdotal experience is that metastatic disease from microscopic primaries tend to behave in a more aggressive fashion.
Yeah.
Because they've declared by biology, haven't they?
Yes, they have. So despite being small primary, it's already gone laterally, and that's where it'd be really nice to have the genomics of that behaviour, wouldn't it? Yeah.
So that's the one thing that bothers me about this history.
Yep. Okay, moving on. Case 2. So, well, my case 2. This lady's 72 now, and she was diagnosed in 1983 and was managed, so that was when I was a final year medical student. She was 36 and she has now been followed up for another period of 36 years. So she's doubled her age and is still being followed up. So she kind of illustrates quite a few interesting issues in relation to recurrence and also perhaps morbidity of the old-fashioned style of therapy. So she presented in 1983 at 36. It was, and I cannot get any information from the file because it was the old-fashioned paper files at North Shore where Ian Hales used to literally write 2 words that were completely illegible and impossible to discern what happened. But it was locally invasive, I think T-N1B, and I'm not sure whether it was classical. So in those days, we didn't really report classical PTC, we didn't report tall cell PTC or other sub-classifications, or we didn't actually report the aggressive variants of papillary cancer. All papillary cancer was papillary cancer. Is that true, Steve? Is that what you remember? Okay, so she had surgery, and I'm not sure exactly what they did in the lymph nodes, but it was 1983, and I presume she had bulky disease and persistent TG positivity. And in those days, the management was lots of radioactive iodine scans done off thyroxine, so at least annually. And the management, as you can see here, illustrates what used to happen. So this is what was done to her. I was a medical student here, an intern here, an RMO here, and I still hadn't met her, by the way, and she had 4 lots of 6 gigabecquerels. And I can only surmise that she had persistent either TG positivity or radioactive iodine positivity or both for her to receive that treatment. But she certainly didn't have stage 4 metastatic disease as far as I can tell. So if you were being subjected to that and then ongoing annual surveillance with thyroxine withdrawal every year, you'd probably start to have some sort of aversion to coming for follow-up, wouldn't you? I certainly would. So she understandably disappeared in the 1990s. and I don't think she had annual off T3 scans at that point. So fast forward to 2001, I was an endocrine consultant, and I'd only been a consultant for a very short time, and I was still doing the sort of things that I'd been trained to do as a registrar back in the 80s. So I met this lady for the first time when she had a recurrence, and it was on the right side of her neck, and it was positive on fine needle biopsy, and Lee, you operated on her. And she had a neck clearance, and I gave her another dose of radioactive iodine. That's what I'd been taught to do. So we're now up to 30 gigabecquerels. I'm feeling slightly embarrassed about it after I tell you what happened next. She still had low-level thyroglobulin positivity after all of this treatment, 2 operations and 30 gigabecquerels of radioactive iodine. So round about 1.5 to 2 serum thyroglobulins. By then, we were moving into the era of really good quality neck ultrasound, but I can tell you it didn't exist at the beginning of this century. We didn't have good quality sensitive neck ultrasound, and we certainly didn't have thyrogen until a bit further along, but eventually she had a thyrogen scan which was clear, and she had a number of clear neck ultrasounds, but she has been maintained on suppressive thyroxine doses, because that's what I was taught as well, that everyone had to have TSH suppression, and her serum thyroglobulin is still positive. So what else has been happening to her? She lives on the Central Coast, and she gets referred to a lot of other specialists up there, and she's been referred to a cardiologist who's diagnosed her with a cardiomyopathy, but she has normal coronary arteries, so I'm not quite sure why she has a cardiomyopathy, query viral. It's not very bad. Her ejection fraction's 40%, and she hasn't had atrial fibrillation, but she's on bisoprolol, and she's got a diagnosis of cardiomyopathy. So I don't know what caused that. She's had renal calculi, and she's also been referred to a renal physician on the Central Coast, and she has a label of stage 3A chronic kidney disease, so she's got another label and another specialist. She's on long-term TSH suppression, so I have done some bone densities. She's osteopenic, but she's never had fractures, luckily. And the latest problem is that in 2015, she had a lump in her right parotid, and long story short, she has a mucoepidermoid carcinoma of the parotid. So she had a parotid, she had resection of that parotid gland. Fortunately, she hasn't had any facial nerve complications from that. And she has had fairly regular neck ultrasounds from David Vivers and myself looking at that area and at the neck and the thyroid bed, and they're all clear. But her unstimulated thyroglobulin remains 1.5. So what should I do with her from now on?
Leave her alone. Leave her alone.
She's got a funny disease, isn't she? Given she's had that much radioactive iodine and she's had a late recurrence, and you sort of wonder what else is going on that she's developed this late recurrence.
Yeah.
But you've operated.
It could have been persistent disease. So that's the thing. You know, when is recurrence ever not persistent disease? It's presumably a clone of cells that's been there all along, that's just been lurking and growing really slowly, you know, like the weeds in the garden and all that sort of stuff. So, it's just to illustrate that her disease has never really gone away. Well, I don't know what happened in the 90s, but it doesn't seem to have ever really gone away, and yet she's still alive and relatively well, apart from the morbidity that's been caused by me and others, perhaps. And in this era, we would probably definitely operate on her rather than giving her all that radioactive iodine. We'd do recurrent neck clearances if needed. Yeah. Okay. So this will be the last case, and then you can all escape early. This is to go right back to square one, where we haven't actually diagnosed cancer yet, and this really goes back to Anthony's talk at the beginning, and this happened just yesterday or last week. A 39-year-old male who noticed a central neck swelling, and he had a neck ultrasound, and he was treated elsewhere on the other side of Sydney. He had a multinodular goiter. There was a cyst in the middle. There was a cyst on the left side, which was 1.9 centimetres, a very sort of benign-looking complex cyst. And on the right lobe, there was a smallish 1.3 centimetre complex solid nodule that was vascular, although vascular is not meant to be a problem these days. And he was sent off for a biopsy, which was Bethesda Category 1, insufficient or not. So he came to me for a second opinion, and we're seeing lots of second opinions now. And I somehow managed to upscale the anxiety and the aggressiveness of his treatment by sending him off for another biopsy of that particular lesion, on the right, because I looked at it on the ultrasound and it just worried me. So he upscaled to Bethesda Category 4, and I actually biopsied the left side, and it was benign at the same time. So what would everyone do with that situation in this room? Young, perfectly well, asymptomatic, apart from noticing that. And incidentally, the thing that he noticed was the actual midline cyst here. So this one wasn't really palpable. So he actually noticed that because it was anterior. No family history, no head and neck radiation, nothing to concern. What would your advice be?
What was the time?
He's an IT guy, an Asian guy. He's married to a pharmacist. He comes with her. She does all the talking. He says nothing. And she has... let me tell you, she has been Dr. Googling to the nth degree and using her pharmacy. I'm not diminishing her intellectual capacity because she asks all the pertinent questions.
My question was just, if you go back to the ultrasound, what's the Thyroid score?
Yeah, I'll show you in a minute. Do you want to? So this is the. So would you like to give me a Thyroid score, Maddie?
Oh yeah, sure.
That's the lump, and that's the blood flow picture.
I'll take it out. We've got good microcalcification there.
Did you do a staging procedure, or did you do the whole
I would take it out. I'll send it to Lee. So.
Okay. I referred him for a right hemithyroidectomy. I thought he should have that one out. I didn't think he needed that one out because he and his wife didn't want him to be on long-term thyroxine. And I thought I was doing a really good job, and that I had connected really well with the patient and his wife. And then I'm standing at the supermarket checkout one day, and she rings me on my mobile phone. And says, "Oh no, we don't. We've had second thoughts, and we don't think he needs an operation, and he's young, and we're not sure that it's a cancer." And I'd already told them that a B4 gives you only a 30% chance of cancer, and they felt that 70% chance of benign disease was not enough to proceed with surgery. And I said, "Well, there's a lot to talk about here, and I'm just at the supermarket checkout, so make an appointment to see me." But he went to see Mark instead, who was meant to be doing the operation. And in the meantime, he paid to have his Afirma gene classifier done in the States, and they gave him pretty much an all clear. They usually they do a panel where if it's all negative, they give you a 96% chance of it being benign. So it's a negative predictive value of 95 to 96%, and now he's decided he doesn't want anything done at the moment. So he's still got this in his thyroid. So do you want to comment on that as an American, where presumably a lot of this goes on all the time?
Yeah, so at UCLA right now we are doing a randomized trial comparing Afirma with ThyroSeq, which is another common type of molecular test that's used. What we don't know is what happens in the long term with patients who have negative molecular testing with long-term surveillance. So part of our trial is doing, we get ultrasounds of these patients every 6 months for the first 2 years, and are going to follow them further out after that to kind of see what happens to these, negative patients. But right now, at the UCLA, this patient would also not be offered surgery based on the negative Afirma test.
So then what would your follow-up be? An annual ultrasound?
Yeah.
Yeah. And would you re-biopsy it at some stage?
Yeah, if it grew, we would rebiopsy.
And you would be hoping that it upscales to be 5 or 6 in order to justify surgery, would you? Or
I think it would depend on the biopsy. In general, if it, I think, grew like maybe 3 millimeters or more, we would rebiopsy, and based off of that rebiopsy result, reassess at that point.
Okay. Great.
We rebiopsied 1,700 biopsies, 1,700 thyroid nodules. There was only a change in 3 cases, so the likelihood of it changing is going to be very low.
Exactly.
And I think we have to remind ourselves this is a screening investigation.
Yeah.
And I think the question that has to be posed back to these individuals is, you're going to live for another 60 years. What are you going to be doing? You're going to be doing this, looking for it. And it reminds me of I saw a cardiologist once. He came along with a big thyroid lump, turned out to be benign. I said, we'd leave it alone. He said, just take it out, get rid of it. So I think we often portray indecision to these patients. I'm not saying that you did that, but I think the reality is that this is going to continue to exist, and we're going to have this uncertainty going forward. 3 millimetres, the lateral resolution on ultrasound is 3 millimetres. It's just nonsense. People don't understand the physics of an ultrasound. You can actually get that simply on the measurement error.
With 3-dimensional.
Now you can do 3-dimensional, but then your error compounds by a cube. It's cubed. It's not. So it's problematic. So this is all wonderful. To some extent nonsense, but this is a screening test, and we need to remind ourselves it's a screening test. And
I suppose, like coming from the prostate world, where we actually understand that a lot of the cancers we were treating were insignificant and didn't need treatment. So sometimes it actually requires a paradigm shift by the clinician to say that this is unlikely to ever take this man's life.
Yeah, well, I agree.
And actually it was another Sloan Kettering surgeon who basically Sloan Kettering works on the way that surgeons talk to their patients about active surveillance. And before he took up his research, their active surveillance was about 30%, and now it's about 70%. So coming back to what you said, it is how we sell it to the patient. And in actual fact, this patient is probably doing the right thing. It's just uncomfortable for us because
it's uncomfortable for all of us.
And although we do talk all the time about the present, the fact is in 10 years' time, it is likely management will be different. And he could be quite right in saying, I'd rather have my thyroid taken out in 10 years' time when you guys know what you're doing with the gene sequencing, you know what you're doing with the treatment. And so I think it's really hard for us, but from a prostate perspective, we actually got it wrong for a long time, taking out irrelevant tumours. And I'm sure we're doing it with thyroid, and we're doing it with melanoma. We're taking out a ridiculous amount of early non-significant lesions, but we just don't know any better at the moment.
Yeah, exactly.
And the other issue with thyroid, it's like breast cancer, it happens in young patients. And a year lost for a young patient is a lot different than a 75-year-old guy, unfortunately.
I think that problem, even waiting, that's not the issue. The problem is how often you're going to be monitoring this stuff. He says that I'll come back in 5 years. That's fine, but we're going to expend a huge amount of resource monitoring this fellow for the next 40, 50 years. He wants to pay for that, that's fine. But should the taxpayer be paying for that?
Yeah. Good point.
I'd argue though that in the next 5 years there'll be a new. It won't be 50 years. In 5 to 10 years' time, we hopefully have gained from what you talked about, and we'll be doing something different. And I know it's really hard for us now because we know about what happened for the last 30 years, but we are over-treating, and it's easy to take something out, but we don't follow the patient and find the time off work and everything else that happened. And
we have good data now from the Asians, the Japanese and the Koreans about active surveillance of known papillary cancer. So let's say he had a category 5 or 6 biopsy and the lesion was 9 millimetres. We have some data on that, and we know that the young people get sick of it after a while, and they don't really want to wait till they've got lymph node metastases. They actually rather have it out. Yeah. Whereas the 80-year-olds are probably happy to sit with that for 10 years.
But that's the same data in prostate.
Yeah, prostate, yeah.
But as the surgeon said when he presented it, it's not the reason that they get sick of waiting is more that the people observing them, the way they talk to them, and I do it all the time, do you really want to have an MRI every year and a biopsy? Come on, I can just give you radiation, it'll be gone. And it is, and they go for that, it's great. All I'm saying is that it is going to change, and I don't know how it's going to change. I'm with you, I don't observe a lot of people. It's the problem, it puts the stress onto us and not the patient.
Both of us, I think, and it's expensive. And
you don't have to necessarily
so there are data in that summary paper that I saying that this sort of approach is actually quite a lot more expensive in the long run. Rory, yeah.
Can I ask Eric and Lee a question each? To Eric, does the Afirma classifier or the Thyroid classifier take account the baseline probability on age, sonographic features and Bethesda category in giving that reassurance? So is it a Bayesian analysis or is it just a pure gene-based prediction? Yeah, so that worries me because this man has a Bethesda 4, Thyroid's 4 with a baseline a priori probability of about 30% of cancer, and you're telling him he's got 4% based on a gene classifier, but it hasn't taken account of the baseline probability. So the question for Lee is, does the position of the nodule change your management? So if you go back, I mean, that's adjacent to the trachea, isn't it?
Well, the thyroid is adjacent to the trachea, yes. So it's not a big issue. I mean, you know, thyroid surgery is very simple, very safe. And I mean, I just saw a patient today who we've been following for 5 years, repeat biopsies, and this time it had grown a bit bigger. And I said, well, let's get another biopsy. And she said, I'm sick of this. Just take it out. So Steve's right. I mean, this is more about managing the patient and the long-term expectations. But yeah, that's like it doesn't look all that worrying.
Is it adjacent to the trachea? If that's a cancer, it's going to be
No, it's not. You know, some do, but that doesn't look. The cancers that go into the trachea tend to be papillary cancers that have an irregular edge. That's just a big round nodule that's likely to be benign follicular adenoma, possibly, you know, something encapsulated. You don't worry about that aspect of it.
Okay, any other questions? Okay, Susie, before you leave, we're going to finish off now. I just want to thank Sydney Vital so much for organising this. and again, to thank Gay and all your other colleagues from ASI for sponsoring this and providing a webcast, so hopefully people who haven't been able to come can learn something tonight, those with small children and things like that that they have to do at home. And thanks to everyone who participated, particularly the speakers and the people who contributed to the discussion. And we can all have an early mark, and you can go and congratulate your daughter for finishing the HSC.